With thoracic malignancies, we can categorize the malignancy by its physical site, either within the lung or outside of a lung. Examples of sites outside of a lung include lymph nodes, bone, or esophagus, just to name a few. We can also categorize the malignancy according to its organ of origin, either cancer originating from the lung or cancer originating from another organ, like the breast, colon, or kidney, for example. We generally refer to malignancies that originate from the lung and are located in the lung as lung cancers or primary lung cancers, while malignancies that arise from another organ, let's say from the breast, for example, are named and treated by the organ of origin. So, breast cancer cells in the lung are not referred to as lung cancer, but metastatic breast cancer to lung. Likewise, when cancer of lung origin spreads to another organ, for example, the liver, it's not referred to as liver cancer, but rather metastatic lung cancer to the liver. In this talk, we'll be spending 95% of the time talking about primary lung cancers and about 5% of the time talking about metastatic cancer to the lung. Let's talk about the more formal classification of cancer in the lung. Cancers in the lung are divided between primary lung cancers and metastatic cancer to lung, and traditionally, most primary lung cancers are classified as either non-small cell lung cancers or small cell lung cancers. The three leading types of non-small cell lung cancers are squamous cell carcinoma, adenocarcinoma, and large cell carcinoma. And lung adenocarcinomas can be further divided between invasive adenocarcinomas and minimally invasive adenocarcinomas. A small number of non-small cell lung cancers don't fit the definition of squamous cell, adenocarcinoma, or large cell carcinoma. Now, not every lung cancer is non-small cell or small cell. On occasion, you may encounter lymphoma of lung origin or other cancers that don't fall under the classification of non-small cell and small cell lung cancer, like carcinoid tumors and salivary gland type tumors. Now, when we're reading pathology reports, the pathologist may go into even more detail. For example, not only may an adenocarcinoma be described as invasive, it may be described as lipidic, mucinous, or papillary, for example. Some minimally invasive adenocarcinomas may be described as adenocarcinoma in situ, and you may encounter mixed types like an adenosquamous carcinoma. Small cell lung cancers may be described in more detail, as may salivary gland tumors and sarcomatoid tumors too. While this is the traditional way of classifying lung cancer, the WHO rearranged the classification a bit a few years ago. Not counting precursor glandular lesions like atypical adenomatous hyperplasia and adenocarcinoma in situ, or precursor squamous lesions like squamous cell carcinoma in situ and squamous dysplasia, the WHO doesn't use the traditional non-small cell lung cancer grouping and treats adenosquamous carcinomas as its own group. Small cell lung cancers fall under a category named neuroendocrine carcinoma, while carcinoid tumors fall under a category called neuroendocrine tumors. With a final category named other epithelial tumors, we arrive at the 2021 WHO classification of primary lung cancer. Admittedly, I still find it more convenient to conceptualize primary lung cancers the traditional way, and the hierarchy is even simpler when I focus on the malignancies I'm most likely to encounter in normal practice. And this is a scheme I find pretty easy to handle mentally on a day-to-day basis. Now let's talk about these guys. 95% of primary lung cancers can be classified as either non-small cell carcinoma or small cell carcinoma, and non-small cells outnumber small cells considerably. 80% of all primary lung cancers are non-small cell lung cancers, and half of non-small cell lung cancers are adenocarcinoma. The other half of non-small cell lung cancers are mostly squamous cell carcinomas. The division of invasive versus minimally invasive adenocarcinomas looks like this, with invasive adenocarcinomas outnumbering minimally invasive adenocarcinomas 4-1. Anyone who's a lumper and not a splitter will ask, why do we break down primary lung cancers into so many different buckets? Well, this bucketing is important to many people involved, from, say, the family medicine doc working in the countryside to the oncologist at a major academic hospital to the patient. While overall 5-year survival for non-small cell lung cancer is around 21%, 5-year survival rates for small cell lung cancers are less than a third of that, at around 6%. Survival rates for small cell lung cancer are very low because small cell lung cancers tend to be very aggressive tumors that grow rapidly. 2/3 are already at an extensive stage at the time they're first diagnosed. Overall 5-year survival of non-small cell lung cancer is 21%, but survival rates vary widely depending on which kind of non-small cell lung cancer a patient has. On one extreme, 5-year survival rates for minimally invasive adenocarcinoma can range from 20% to as high as almost 100%, while 5-year survival rates for large cell carcinomas aren't much better than for small cell lung cancers because minimally invasive adenocarcinomas tend to grow very slowly and metastasize infrequently, while large cell carcinomas grow quickly and are usually not detected until they've already metastasized. So, knowing which bucket a patient's lung cancer is in may have an important impact on establishing what their prognosis may be. Knowing which bucket your patient's lung cancer is in will also inform the treatment options that are most likely on the table for them. For small cell lung cancers, a surgical cure is usually not an option, and patients are usually looking at chemotherapy and radiation. On the other hand, a surgical cure is usually a possible choice for minimally invasive adenocarcinoma. In fact, because they grow slowly, therapies like radiation and chemotherapy may not always be highly efficacious for minimally invasive adenocarcinomas. For the other types of non-small cell lung cancers, a surgical cure is typically only possible in cases where the lung cancer was discovered at an early stage. Demographics vary between primary lung cancer types too. Small cell carcinoma, large cell carcinoma, and squamous cell carcinoma tend to occur more frequently in men, while adenocarcinomas tend to occur more often in women. While it's unusual to encounter small cell carcinoma, large cell carcinoma, and squamous cell carcinoma in your younger patients, adenocarcinomas can occasionally occur in younger people. And while it's uncommon for never smokers to develop small cell carcinoma, large cell carcinoma, and squamous cell carcinoma, adenocarcinomas can sometimes occur in your never smokers. Here's a visualization of the strength of the link between smoking and different primary lung cancer types. This is a pie chart showing the distribution of lung cancer types from earlier. Smokers account for almost the entirety of the wedges that correspond to large cell carcinoma, small cell carcinoma, and squamous cell carcinoma. However, smokers account for only about 2/3 of the adenocarcinoma wedge. As a consequence, smoking appears to be responsible for something in the vicinity of 80% of primary lung cancers, while many of the remainder of lung cancers may be attributable to other factors such as pollution, radon, asbestos, and other materials on this list. Switching gears a little. Sometimes a primary lung cancer releases hormones or substances into the bloodstream that may trigger an abnormal immune response and manifest in non-lung related symptoms elsewhere in the body. We refer to this phenomenon as a paraneoplastic syndrome, and paraneoplastic syndromes can sometimes be the earliest sign to a primary care doc that a primary lung malignancy may be lurking and undiscovered. There are 6 lung cancer-related paraneoplastic syndromes I think it's good to be familiar with. Hypercalcemia of malignancy, caused by abnormal production of parathyroid hormone by a primary lung cancer, which can result in symptoms such as bone pain, polyuria, and polydipsia. Syndrome of inappropriate ADH secretion, caused by abnormal production of antidiuretic hormone by a primary lung cancer, which can result in symptoms like altered mental status or confusion. Ectopic Cushing syndrome, caused by abnormal production of ACTH by a primary lung cancer, which can result in a panoply of symptoms caused by high levels of cortisol in the body. Lambert-Eaton syndrome, caused by an autoimmune disorder occurring at neuromuscular junctions, which can result in progressive proximal extremity weakness. Hypertrophic osteoarthropathy, which can result in periostosis and joint inflammation. And carcinoid syndrome, which can cause symptoms such as diarrhea, flushing, bronchoconstriction, and abdominal pain. Because different types of lung cancer tend to have associations with the presence of, and sometimes different, paraneoplastic syndromes, a primary care doc who notices symptoms that seem like one of these syndromes may be triggered to do a more in-depth search for lung cancer and possibly catch one much earlier than if the lung cancer manifested by structural changes in the lung or more severe systemic changes like weight loss. Now, let's do a brief dive into the histopathology of the different types of lung cancer. Let's start with squamous cell carcinoma. If you look at the lining of the central airways, you'll find that many ciliated cells within the airway lining that are responsible for the mucociliary escalator that clears inhaled particles and pathogens out of the lungs. And you'll find many mucus-secreting goblet cells too. You'll find neuroendocrine cells that serve as sensors and signaling devices for different conditions, such as hypoxia. And you'll find a small number of club cells that are responsible for detoxifying harmful substances we inhale into our lungs. And finally, you'll find many basal stem cells, which are progenitor cells for different epithelial cell types. In some individuals, basal cells may undergo squamous cell metaplasia, which in some cases can evolve into squamous cell carcinoma. Since basal cells are predominantly in the central airways, squamous cell carcinomas tend to also be central in their distribution when they occur. As squamous cell carcinomas tend to be more central in their location, early symptoms, such as hemoptysis, can sometimes present. Invasive adenocarcinomas tend to occur more peripherally. When you look at the peripheral airways, the lining is a bit different than what you encounter in the central airways. Ciliated cells responsible for the mucociliary escalator are present peripherally, but fewer in number. Neuroendocrine cells for detection and signaling are very few in number, and goblet cells are very rare. However, club cells responsible for detoxifying substances are present in much greater numbers peripherally, and invasive adenocarcinomas can occur when club cells go bad. And that's why adenocarcinomas tend to occur more peripherally as opposed to squamous cell carcinomas. What's interesting is that after cigarette filters were introduced in the 1950s, the distribution of lung cancers we saw in smokers shifted away from squamous cell carcinomas towards adenocarcinomas. Many folks believe that's because the particles smokers inhale through a filtered cigarette are on average much finer than the particles from an unfiltered cigarette, and that these finer particles can travel much more peripherally in the airways. Minimally invasive adenocarcinomas tend to be peripherally occurring too. While you may encounter goblet cells and club cells in the alveolar ducts, the alveolar sacs primarily consist of type 1 pneumocytes, capillaries, and type 2 pneumocytes responsible for producing surfactant. Minimally invasive adenocarcinomas tend to be very peripheral in distribution since they usually arise when type 2 pneumocytes go bad. Large cell carcinomas have traditionally been diagnosed in both central and peripheral locations, which is actually sort of interesting since with the advent of more precise diagnostics, many large cell carcinomas are now being reclassified as squamous cell carcinomas and adenocarcinomas. Carcinoid tumors may occur both centrally and peripherally, since the neuroendocrine cells from which they may arise can be found in the lining of both central airways and more peripheral airways too. A few takeaways about carcinoid tumors. They generally aren't associated with smoking. Folks sometimes divide carcinoid tumors into typical and atypical buckets. Typical carcinoids are more common and exhibit less aggressive behavior, while atypical carcinoids grow more rapidly. Like carcinoid tumors, small cell lung cancers also arise from neuroendocrine cells, particularly peribronchial neuroendocrine cells, which explain their strong predilection of presenting very centrally in location. A basic appreciation of this histopathology of primary lung cancers can go a long ways in helping us predict, understand, and remember the imaging characteristics of primary lung cancers. Different types of primary lung cancers arise from different cell lines, and these cell lines are not distributed uniformly. The basal cells that give rise to squamous cell carcinomas predominate in the central airways, while the club cells that give rise to invasive adenocarcinomas predominate in the distal airways. And type 2 pneumocytes that give rise to minimally invasive adenocarcinomas are found in the alveolar sacs. Neuroendocrine cells that give rise to bronchial and peripheral carcinoid tumors may be found in the central or peripheral airways, while the neuroendocrine cells that give rise to small cell lung cancers are situated in a peribronchial and therefore very central location. These histopathologies, occurring at a cellular level, directly influence the macroscopic observations radiologists make on chest radiography and chest CT. That's why squamous cell carcinomas usually present on chest radiography as central masses near the hyla, central masses that may obstruct a lobar bronchus and result in obstructive lobar atelectasis. Compared to adenocarcinomas, squamous cell carcinomas are more likely to centrally necrose, as they may grow somewhat more rapidly and outpace their vascular supply. And when they do necrose, you might sometimes see an air fluid level within the mass. The CT imaging features of squamous cell carcinomas mimic the same features you'll recognize on chest radiography, including post-obstructive pneumonia. Let's look at a few squamous cell carcinoma cases. Here's a case of a squamous cell carcinoma that presented as a central left upper lobe lung mass and obstructive left upper lobar atelectasis. Due to the abrupt occlusion of the left upper lobe bronchus by a mass which was FDG avid with a region of central necrosis. Here's another case of squamous cell carcinoma which appeared to invade the lumen of the right pulmonary artery on this enhanced chest CT image, in addition to central airway occlusion that resulted in much consolidation peripherally, which probably represented a combination of post-obstructive pneumonia and atelectasis. And here's a less typical case of a peripheral squamous cell carcinoma, which was discovered at an early stage by lung cancer screening. Invasive adenocarcinomas tend to be slower growing and generally occur more peripherally than squamous cell carcinomas. They may present as a nodule surrounded by a region of air-filled lung parenchyma, though can present as a mass in situations where they've had a chance to grow silently. Less common mucinous or lipidic adenocarcinomas may even appear consolidative and sometimes resemble pneumonia. Invasive adenocarcinomas can metastasize relatively early. Here are a few examples of invasive adenocarcinomas. And here's an invasive adenocarcinoma in the left lower lobe that presented as a large peripheral lung mass. Mucinous adenocarcinomas can sometimes appear consolidative and mimic a pneumonia, like this case in the right lower lobe, and on occasion may appear quite floridly multifocal, as in this case, where soft tissues windows revealed some regions of atypical calcification within the consolidative areas. Not every case of adenocarcinoma presents typically, like this left perihilar adenocarcinoma. Minimally invasive adenocarcinomas commonly present as a subsolid lung nodule on chest CT. Since they're subsolid, they're often invisible on chest radiography. They can appear quite faint in some cases, such as this example in the lateral left upper lobe of a patient. Large cell lung cancers can grow quickly and may often be undetected until they've already metastasized. Due to their rapid growth, they can necrose and cavitate centrally, like squamous cell carcinomas. Many large cell lung cancers present as a large mass that may be either central or peripheral in location. Here's an example of a large cell lung cancer presenting as a left perihilar mass. While here's a different example of a large cell lung cancer presenting as an irregularly marginated left upper lobe lung nodule that had already metastasized to the left lower lobe. Small cell lung cancers are characteristically central in location. Because they're so central, they have excellent access to the hilar and mediastinal lymphatic network, allowing them to spread rapidly, resulting in masses throughout the mediastinum and hyla that often resemble lymphoma. On chest radiography, mediastinal widening and hilar enlargement or masses are typical findings, while on CT, you may even see direct invasion of mediastinal and hilar anatomy and mass effect on structures such as the SVC. Here's an example of a small cell lung cancer presenting as bulky, confluent mediastinal and left hilar masses, in addition to metastatic bulky left internal mammary lymphadenopathy. Here's a case of small cell lung cancer presenting as bulky solid masses in the mediastinum and right hilum. Bronchial carcinoid tumors usually present as relatively central, while circumscribed round nodules and masses. Due to their central location and typically endobronchial location, obstructive lobar atelectasis is common. On CT imaging, carcinoids may exhibit calcification and can avidly enhance on contrast CT. Here's an example of a carcinoid tumor presenting as a central left lung mass. And here's an example of a carcinoid tumor presenting as a central right lung mass with avid enhancement. This is an example of a bronchocarcinoid tumor presenting as an endobronchial nodule in the bronchus intermedius. And here's a different example of a central right lower lobe bronchocarcinoid that's obstructed the bronchi centrally, resulting in the development of several mucoceles upstream. This is an example of a central left upper lobe carcinoid tumor that's obstructed the left upper lobe bronchus, resulting in a juxtaphrenic peak on the left side, a Loof-Sickle sign in the upper left chest, and marked anterior displacement of the left major fissure due to obstructive left upper lobar atelectasis. The corresponding CT images showed a central left upper lobe tumor that included a small amount of calcification and tight obstructive left upper lobar atelectasis. Peripheral carcinoid tumors typically present as a solitary lung nodule surrounded by air-filled lung parenchyma. If you look carefully, sometimes you may recognize involvement of a subsegmental bronchus. On PET imaging, many may not be FDG avid. Here's an example of a patient with a peripheral carcinoid tumor. And here's an example of a patient with peripheral carcinoid tumors, which were not FDG avid on PET imaging. Hopefully these cases showcase the different imaging tendencies of various primary lung cancer types, but also how some overlap may exist in their individual presentations. In our final few minutes, I'd like to talk about metastatic cancer in the lung. Here's a table I've created for you with primary cancer along the horizontal axis and the metastasis site along the vertical axis. There's a bit of information encoded on this chart, but the main takeaways for now are that the site that primary lung cancers most often may metastasize to are the adrenal glands, bone, brain, liver, and lung itself, and that pretty much every primary malignancy can metastasize to the lung, which is why chest CTs are such a common study in oncology. Of all the primaries on this chart, I'd say that the top non-lung primaries that may metastasize to lung are breast cancer, colorectal cancer, renal cell carcinoma, and head and neck tumors. Metastases to the lung may present in 3 different ways: as parenchymal nodules, as endobronchial metastases, and in a miliary or random nodular interstitial pattern. Parenchymal nodules are far and away the most common presentation of metastasis to the lung. Parenchymal nodules can be solitary, few, or many, range from small to large, of similar or varying size. Parenchymal lung metastases are most often solid, tend to be more well circumscribed and rounder compared to primary lung cancers, and they tend to be more often peripheral in location. Here's an example of a solitary colorectal carcinoma to lung, and here's an example of a solitary renal cell carcinoma to the right lung. In this case of lung adenocarcinoma metastatic to lung, the nodules are very small but numerous, while in this case of metastatic breast cancer to the lung, the nodules are a bit larger and numerous. While in this case of metastatic thyroid cancer to lung, the nodules are tiny but innumerable. Lung parenchymal metastases are typically non-calcified. However, in the setting of osteosarcoma, metastases may be completely or partially calcified. Endobronchial metastases are a more uncommon presentation of metastasis to lung. The most common sources tend to be colorectal carcinoma, renal cell carcinoma, melanoma, lymphoma, and lung cancer. In this case of melanoma, the lung metastasis resembles a mucus plug in the posterior left lung, but unlike a mucus plug, its contours aren't as straight, and its morphology appears more nodular. While in this case of lymphoma, the metastasis is actually endotracheal and could have been mistaken for a mucus glob. Miliary pattern metastases are another rare presentation of metastasis to lung. Most common sources are renal cell carcinoma, melanoma, choriocarcinoma, thyroid carcinoma, and osteosarcoma. And the pattern resembles the diffuse random nodular interstitial pattern we customarily think of in diseases such as miliary TB. Let's summarize our take-home points. Primary lung cancer is not one uniform disease. Different types exist and are classified by what type of lung cells went bad, and each type may have its own imaging disposition, treatment, and prognoses. Likewise, metastatic cancer to lung is not one uniform disease. They may come from primary cancers of practically any organ in the body, present in different ways, require different treatments, and come with different prognoses. The location and distribution of malignancy in the lung can give us a preliminary hint as to the diagnosis sometimes, but ultimately the diagnostic process is a multidisciplinary task involving an entire team, including radiologists, pulmonologists, surgeons, and pathologists.